And I'll just do a quick introduction. But our speaker today is Jackie Griffin, and she's at Northeastern right now, and she's an associate professor in the Mechanical and Industrial Engineering department at Northeastern University. She completed her master's and BS degrees in Industrial and Systems Engineering department at Lehigh University. And I'll let her screen share and start her presentation.
Sounds good. Okay, let me share my screen. Okay, good afternoon, everyone. So as Renata mentioned, my name is Jackie Griffin. I'm an associate professor of industrial engineering here at Northeastern University in Boston. You can see we're having a gray day behind me today. So today I'm a little bit more of my background. I do a lot of different health systems engineering work. Today I'm going to focus a little bit on my outpatient work research. Other big areas of kind of health systems engineering that I focus on, I lead a team focused on drug shortage management, kind of from the global supply chain all the way down to how it's handled at hospital operations or pharmacy operations, and a variety of other additional emergency management, healthcare delivery initiatives, and a few things related to COVID. But today I'm actually not going to focus on the COVID work. I know that's been a focus a lot of the presentations in the past weeks. So feel free to stop me if you have any questions or just type them in the side window. So what am I going to talk to you today? So today I was asked to kind of focus a bit on the research that I've been doing over many years. I've been at Northeastern for, I think I'm on my 9th year at this point, specifically focused on this concept of flexibility and adaptation within healthcare systems. Really specifically focused on operations, and most of the projects we've been working on over the past 9 years in Boston, we've worked with Boston Children's Hospital, Brigham and Women's Hospital, Tufts Medical Center, Beth Israel Hospital, and I don't know if I'm missing a last one. So me and my team of Ph.D. students, a few master's students along the way, have just been working with a lot of different healthcare systems to help them think about new ways of designing and delivering care. So let's get started. So as I mentioned, I'm not going to focus on COVID, but as with everything, COVID is currently drawing attention to challenges in our healthcare system. So I just pulled a few different headlines that have come out over the past few months, thinking about how the pandemic is prompting thinking about flexible healthcare design and all the capacity issues we're running into. Right before this started, I was looking at New York Times, and on the front page of their app, they had a discussion of hospitals again starting to run out of ICU spaces across the country. So we've always known that healthcare was a limited capacity, but this has really kind of drawn and focused attention on the importance of our healthcare operations being able to be flexible and adjust to the changing needs, oftentimes in really a short period of time. And another concept of really designing for that flexibility, making sure that when we actually design the system and design the operations, that we're accounting for the flexibility and not getting stuck in the process of presuming that the systems won't continue to evolve over time, or then making sure they're more agile to change. But it's not only, so while the pandemic has really drawn most of its attention to really inpatient care for the most part, we know that flexibility is not just critical during a pandemic, and it's not only needed in inpatient care. And in fact, this has been, as I mentioned before, an area of focus for me and my research team over the past few years, as we've been working with a lot of different outpatient clinics to help them think about their operations, think about how they can drive change and improvement there. So we know that inpatient, outpatient, and emergency departments are all interrelated. And my statistics are a little older now, but we've seen this increasing trend in the demand for ambulatory care, so outpatient care services. So the number of outpatient hospital exceeded 125 million people in 2011, and this was a 24% increase just in comparison to the year before that. So we're seeing a trend in the increase of these outpatient services, and of course, this is more individuals that the limited capacity has to be able to serve. And so while a lot of research papers often use, many times will focus on inpatient care, it is kind of a critical point of also making sure we're really focusing on how to best operate our outpatient care facilities. So today, what I decided to do is to give you kind of a broad sample of 3 of the different projects that I've worked on that have to do with flexibility, adaptation within healthcare systems. They all kind of come at it from a different side. And I thought that would kind of go together nicely. So I'm not sure how far we'll get into the last one, but we'll see what time allows. So the first one I'm going to work on, this is a project we had actually done multiple years ago of thinking about flexibility. How do we analyze the value of resource sharing and resource flexibility within an outpatient center? In the second case, we talk more about flexibility in the actual process. So in this case, in the model that we developed for the system, we actually created a simulation model that was designed with the concept of flexibility to be used for multiple different healthcare centers. And then finally, another project related to really prioritization of patient flows. But again, we look at, when I'm talking about flexibility, we're talking about being able to adapt the operations based on the current state of the system. So not being stuck in the system of saying, this is how we do this, and every day, regardless of what's going on, we're going to continue to do the same thing. We're trying to think about how can we embed in these systems the ability to change operations, change policies, reflect based on kind of what's ongoing in the system. Okay, so let's jump into the first project that we did. And this was actually one of the first few projects I did actually here in Boston. So what we focused on is we had an outpatient cardiovascular clinic. There was 60, which had about 60,000 patients visits per year to this clinic. There was about 160 physicians, fellows, and nurses. And when we came in to kind of work with them, what we're seeing is they were reporting long wait times, approximately 23 minutes each patient, and they had long patient length of stay of 76 minutes. So now, while the entire cardiovascular clinic was 60,000 patients per year, they actually had 3 different clinics within there. This particular project only focused on the largest of those 3. And I'll show you kind of the process that we went through to try and identify where do we intervene, how do we analyze this system and understand what should we do first. And we eventually started looking at exam room allocation policies and some flexible assignments there. So further, when we kind of started this, we did an analysis. In this case, we did multiple time studies to really try to understand what's going on in the system. And some of the things that came out of it is we actually looking at what's going on in the waiting area. In this case, 76% of the people sitting in the waiting room were just there waiting because there was no exam room available, and 40%, but exam rooms on average were only utilized 40% of the time. So it kind of was a contradictory story, and we wanted to dig in and understand it a little better. I have more details on that in the next slide. Okay, so we're going to focus on room allocation policies. Many different people have focused on thinking about room allocation policies. Many times what they're doing is they're thinking about physical space allocation. So we have a limited amount of square footage in a location. How do we allocate those spaces, whether it's in design or just how to kind of one time kind of allocate the space among different needs. And there's lots of research on that. But one of the things we wanted to focus on, which is a little different than what we had seen in a good amount of the literature, was focusing on actually how the exam rooms are actually allocated to different procedures, different providers, et cetera. So within this model, we came in and we looked at understanding how rooms were assigned each provider, including that ratio, how that related to the number of patients being seen by each provider. Also in this particular clinic, we saw a flow pattern where each individual actually saw two different providers, first the medical assistant, then the physician. And so we looked at how decoupling those two could actually perhaps make the system run more efficiently. And there's also provider documentation. I won't discuss that much here. We have a few papers on looking at actually, it seems like a small part of the care process, but we have a few different models where we've looked at different methods of how documentation and note-taking is done, and how moving it in and out of the rooms can actually, or changing it where it happens in the process, can actually affect length of stay and wait times as well. But so here's my initial clinic analysis. I showed you a few of these on the first slide. So what we did is we went in and we did, I think, 2 weeks for the initial time study. We sampled and tried to understand what is the general process for a typical patient and for each of the different providers in the system. So here we've broken it up and we said the check-in, then sitting in the waiting area. Here you can see about 18 minutes or so waiting in the waiting area. At that point, a medical assistant would then meet the patient, bring them back to a room, complete any of the initial intake and an EKG if necessary. At that point, the patient would then be left in the room, wait there for the physician to come in, and then finally check out and perhaps go to phlebotomy for any blood draws as needed. And this is often what we see presented. We say, this is the average time in the waiting area. This is the average time spent with the medical assistant in the exam room. But one of the things we wanted to do is really kind of dig deeper. And we were able to do this by creating a discrete event simulation of the system to understand, even when you're spending time in the waiting area, why are you in the waiting area? Not just how long are you there? What resource is constraining you and making you wait? And so we were able to dig a little bit deeper. And so what we found is when we looked at the waiting area in more detail, we saw that about 75% of the time, people were waiting because there was no exam room available for them to go into. And 25% of the time there was perhaps a room available, but in fact that all the medical assistants were busy and no one was available to actually take them back. Similarly, we found that when you spend time with the medical assistant, 70% of that time on average was actually performing the EKG, 10% or 20% for vitals, but we also found 10% of that time on average across patients was just because there was no EKG machine available. And we could similarly see the physician visit of how much time is actually spent waiting for the physician and actually the time spent with the physician. And we thought this gave a more descriptive picture of what was actually ongoing in the system. And so one of the things that stood out to us was understanding, are rooms being allocated efficiently? We saw this wait times because there was no exam rooms, but we also saw that 40% of the time people were in the exam rooms, they actually weren't getting any value added, right? They were just sitting in there waiting for the physician. So we wanted to look at some creative solutions. As I mentioned before, the chief complaint among patients before coming into this clinic was really just the fact that the clinic was always backed up, long waiting times, et cetera. So we wanted to look at our resource utilization as we focused. We also got this interesting idea. Even though people are waiting for rooms, we often found that rooms were only really kind of fully utilized 50% of the time. But our medical assistants were highly utilized, as were our physicians. So we wanted to think about creative solutions here. So we created a discrete event simulation. In the interest of time, I will not. I think this paper was shared with everyone beforehand, but I'm happy to provide the reference if anyone's interested. Created a discrete event simulation, looking at all of those different patient flows from the waiting area to each of the exam rooms, coming out and checking out, etc., and the times related to it. One thing that we've often found in our healthcare projects is that we often use a triangular distribution just because intuitively when we present this to the clinic, the triangular distribution is one that people can generally have kind of a gut feeling as to whether or not it kind of makes sense. And we found that in most cases this has not stopped the ability for us to validate the results of our model. And so down here in the last section, you can see what we were specifically validating the model on patient length of stay and wait times, since those were the chief complaints we initially started out focusing on. So what we wanted to do was looking at examining changes to room allocation policies. So we wanted to look at this decision of how many rooms does each physician need? Do they need 1 exam room or 2 exam rooms? This would, of course, be expected to be dependent on the number of patients they're going to see. And we also wanted to understand how could we use or build off the fact that the clinic was designed, had this kind of 2 phases of care for the medical assistants and the physicians. How could we build off that? So we looked at using our simulation model to analyze how changes in some of these policies might actually change patient care. So the first one we looked at was the medical assistant room allocation policies. And you can see that kind of saw it as a spectrum. So in one way we saw, we had medical assistants were restricted to perform the EKGs and vitals in the room that was assigned to that patient's physician. So if you're going to see Dr. X, you wait until one of the rooms related to Dr. X is open, and then you would put them in that room, complete the EKG, complete the vitals. And this is a typical model of care that we often see. We said if you really, if you want to go for the other direction, you could get a completely flexible system, have all rooms available at all times, complete the vitals and complete the EKGs, any room available as long as they're available. This, of course, will require then afterwards taking the patient back to the waiting area in between. And we know, I mean, as with engineering, we oftentimes focus on, more flexibility is great for a system, it makes sure that we use our resources better. But when we talk about actually implementing it, there are certainly challenges on actually implementing these systems. They can be very hard to handle. So we wanted to say, what's kind of the middle ground between the two? And so we wanted to look at an adaptive system that took and achieved some of the benefits related to like this flexible pooled system and a more fixed system. And so we wanted to look at this strategy. And so the strategy we looked at is when a physician is behind schedule, the medical assistant is going to visit that patient in the first available room so that they're all ready to go as soon as the physician is then available. So the idea was to kind of get patients prepared if a particular MD was running behind schedule. And part of where we got this idea from was actually from the shadowing and the data collection with the medical assistants. We saw that when things got really, really bad, that was oftentimes what they would do. And so what we were doing is really building off of the heuristic they were coming up with to actually see if we were able to add this into the system, how much more benefit could we get? So we looked at the room allocation policies. Basically, the parameter we were trying to identify was to say how many people need to be waiting for a physician before we kind of spring into kind of using any available room. And so you see on the bottom, we have the number of patients that are waiting before we transition to that flexible policy. And so here we were able to see the fully flexible policy says use this no matter what. Then the adaptive policy is kind of where we change that value in between. And then that fixed policy is equivalent to doing what was currently being done. And so the original length of stay here was 76 minutes. So right where you end up kind of with this fixed policy. And so you do see that by implementing this, you might be able to kind of shave 4 or 6 minutes off on average of every patient. So that's a little, probably about 8%, 7 or 8% of the in total time. So a significant difference when you think about over an hour wait in time, but may still be difficult to actually implement in practice. We acknowledge that. So we wanted to continue thinking about other ways to think about flexibility in this system. So the next one we looked at was actually this room allocation policy. So before it was just what room are you going to use to complete the EKGs and vitals in. Now we wanted to look at the beginning of the day. How do you allocate those rooms, the rooms in your clinic, to your physicians? So just for ease of presentation, we kind of narrowed this down and just looked at each of this. They had six rooms. It kind of, they had a hallway with 3 rooms on each side, and that was repeated throughout their clinic. And typically what we saw is then in each of those hallways, you had 4 different physicians. 2 of them each had 2 rooms, and 2 of them each had 1 room. So this was our starting point. And that was generally proportional to the number of patients being seen, but not always perfectly. So what we wanted to look at is a new policy or new ways of assigning physicians to rooms. And again, as we're trying to think about flexibility, we're trying to figure out what are the parameters? How do you even define flexibility in this system? And so we looked at it in 2 different directions. The first one was we defined as physician flexibility. So if you see here, we wanted to look at, of the rooms that are shared among multiple providers, how many people are sharing it. So in the left-hand corner, we see for the 2 shared rooms, they're both shared by 2 different providers. And then we see these shared rooms at the bottom are shared among more of the providers. Now, every time you include a new provider being shared, it's a lot more logistical challenges to how do you actually manage that process. The other side that we looked at was focusing on the space flexibility. So we also wanted to look at the number of rooms that are being shared. So on that bottom row, we said only 2 of those rooms are kind of rooms that are shared. And then we looked at what happens when we share more of the rooms. Now there's multiple different ways you could find balances of space flexibility and physician flexibility. These are the ones that we kind of came up with in this analysis, but there certainly would be other options. So we wanted to see what is the effect of this? And so we've color coded it. So the current length of stay is 76 minutes. So all 9 of these in this square over here, all are less than what the length of stay was in our initial system when we started the project. And the shading gives you an idea of what the length of stay goes down to. So we start to see that we see this significant difference once we move into this upper right 4 cells, right? We see a jump of about 8 or 10 minutes moving from the low physician flexibility or the low space flexibility. And this really points to the concept that you don't need to fully pool everything to end up with this 61.2 up in the right-hand corner. You can get most of that benefit by just changing both parameters, but changing them together. So right, you only get about a minute or so more moving by kind of going from the medium to the high level. And this is a constant theme we have seen across lots of different projects we've done, is that oftentimes when we start thinking about flexibility, we think about implementing lots of flexibility or only working on flexibility with one parameter. And many times we see that by kind of going part of the way and hopefully keeping the logistics and the challenges of management lower, we can achieve just as much, but we need to make sure we understand how those things kind of pair together. Really seeing the complexity of the system. This has come up in many different projects. So the nice thing about these results is, in addition to having a lower average, we actually saw that they had also a lower variance in the length of stay when we actually looked at the box and plot as well. So these seem to be performing well, not just on average, but also kind of had a smaller range. We did go ahead, and you guys already have access to the paper, but we looked at additional analysis effects as well. Many different ways we could measure the system. Of course, these were not the ones that we had validated the system for, but so we wanted to we looked at the room allocation policy. We looked at clinic closing time. And again, we saw that those top 4 all had a significantly lower closing time, almost by an hour in some cases. We looked at the waiting time analysis. We saw that the total wait time was down, as would be expected when the length of stay goes down. We did start to see a change in distribution about where people spent waiting. We expect that when we're kind of using our exam rooms better, people are going to spend perhaps more time in the exam room, but once they get into spending less time in the waiting room, but once they get into, I apologize. Their waiting time in the waiting area goes down, and then they spend a greater percentage of their time waiting in the exam room. Right, we're able to get them into those rooms quicker. And then finally, what we did is to go one step further and look at combining these 2 steps of these 2 different room allocation policies. And so what we did is we looked at what happens if you pair together using these new flexible MA room policies, as well as the MD room allocation policies. And we had fixed the flexible and then the adaptive, which kind of was the middle ground there. And again, we see just by moving to from the fixed model, which is where they had started, to an adaptive model, even if that threshold point was low, gave you a lot of benefit. But overall, using the simulation, we found you received a lot more benefit just from implementing the physician room allocation policies than from those MA room policies. And that was really the benefit of using a simulation, is we know all of these different components work together, and it allows us to kind of identify which way is most effective. Right, and we see that kind of the red was those over here. So we looked at lots of different ways to think about what we kind of saw was new related to literature is we don't see this concept of room assignment policies and outpatient clinics focused on as much. There is a lot of research that focuses on it in the inpatient setting, but we did see that kind of by rethinking it, we could really drive down those length of stays and those wait times. So we created this new taxonomy. So Renata, are there any questions on, I'm not sure where I am on time. Any questions so far?
Yes, we do have a couple. I think you're good on time. We have about 30 minutes left. Would you like me to ask them now, or do you want to keep them?
I can ask them. Why don't we answer them now? That's fine.
Okay. So we have a couple questions from Anne, and her first question is if time at phlebotomy was included in the total visit time.
In the particular, this analysis here, phlebotomy was not included. So okay. The original slide, from this analysis, we actually took out phlebotomy, but that first slide was what we actually presented to the hospital leadership when we were originally starting the project. So in that case, we did include phlebotomy, but we can, even though it was part of it, we kind of considered it outside of the scope of the project.
Okay. And then her second question is if you've done any analysis for other projects on the impact of allowing returning patients to have their blood work drawn prior to a visit, so the new results are available at the appointment on the length of visit.
We have not looked at anything around timing of testing. We have another project that we did which I don't think I'd brought in here, where we actually focused on, we did a full simulation of an orthopedic rheumatology and radiology clinic. And not exactly the same thing, but we saw that for one of the two of them, I think it was orthopedics, they always did their x-rays before the appointment, so they scheduled that into the system. And for rheumatology, we saw that they were often after the system. And so we do have a paper where we looked and saw how those different decisions at orthopedics and rheumatology in terms of their patient flow kind of came together and affected the radiology services, and looked at kind of challenges in managing that. That was a really, so it's not in blood draws, but it is in lab services. That was an interesting project because while they were both using the same X-ray radiology services, they typically didn't consider each other when they were thinking about their scheduling. And this was actually a project we were trying to model their system before they moved into a new building. And so it was a lot of management and helping them kind of see via the simulation how they affected each other. And so it was it gave the simulation in that case actually gave them a way to see and also talk about their interactions between their systems, where typically they kind of had previously just operated on their own and just kind of said, it's a shame that it seems like people are always late coming from radiology, but without seeing kind of the role of it and how those pieces all came together. But no, we haven't specifically looked at that.
Okay. And then we do have another one, and it's from Catherine, and she asked that the pool policy seems like it could be confusing for physicians to know when to go next. And did you explore their willingness to try new patterns?
We did not do we didn't specifically go in and kind of talk about this. Part of why we thought it was reasonable to look at this here was because we actually saw that the MAs were kind of doing this under really constrained settings. They could kind of like adjust the system or kind of get a picture of it. We didn't go in and really figure out how much they would be willing to. I agree that a pooled policy would just be very difficult to manage. And that's part of why we wanted to see, can we get some of the benefit of pooling without the air traffic controller that would be needed to literally sit there and kind of tell everybody where to be at a time. Yeah, I mean, I think that's precisely the case. We jumping to just assuming pooling everything it's not going to be effective if you can't actually manage the clinic. Because they were in these like 6 rooms together and the physicians worked there, it was kind of a small enough room area that we assumed you could kind of manage it. If you had taken the 18 rooms across the clinic and fully pooled those, that would be kind of completely impossible. But we figured with 6 rooms in one hallway, as long as the MAs were kind of on top of who was where, it would be feasible, but we wouldn't have gone to like 18 rooms where you're heading down the hallway and around a corner and things like that. Also, we have another project where we actually did a simulation for design of a clinic where we actually looked at patient and provider movements based on different design schemes. And you see that actually makes a big difference too.
Mm-hmm. So. Okay. Oh, yeah. And those are all the questions.
That's all now. Okay. So yeah. There's lots of things I could talk to you if I had hours, but okay. So the next thing we did is we kind of moved into thinking about flexibility a little differently. And we do actually look at flexible room usage in this project. After that first project we did probably 7 years ago, I think we started on that project. We started really on our subsequent projects thinking about this idea of how do you use the rooms when we kind of go in and help different clinics. Became kind of a staple thing to analyze in our projects. So I don't know how much people have kind of come up with discrete event simulations here, but here's kind of my brief overview of the pros and cons of the approach. The nice thing is it allows you to really analyze lots of different changes in the system without actually having to implement them. For anyone that's actually done this, we know that they take an extremely long amount of time. They can be very costly financially, depending on how many people you actually have to hire as well. And the other con that I don't think is talked about as much in the literature is the fact that we always go in and we typically build a simulation model for a particular clinic. And we create it, perhaps do the analysis, many consulting firms deliver the results, but then you're done. And then maybe a few years later, they've changed a few things and you kind of have to almost start from what you had before and kind of continue, or you just need to start over. It also means that analyzing one clinic, sometimes we can get ideas about what might work in another clinic. But because they're so different from each other, it often makes it hard to fully translate those ideas into another setting. So lots of really good benefits for the clinic you're studying, but sometimes can make it harder to continue to find benefit when moving to a new similar system or even just a few years into the future. So when we came in and we were working here with an orthopedic clinic, they came in and they said, we actually have 3 different clinics. We have a sports medicine clinic. We had one in Boston, and then we had one in the suburbs. And so we came in, we're trying to think about how to analyze their system. One of the other reasons that we started working with them was also that they were in the process of looking at building a new facility. That was put on hold for reasons external to our project. But through the simulation model, we were able to kind of deliver something that could be used to actually help manage their system, even when it perhaps changed in the future. So the hospital under study, we're focusing on the outpatient, is one of the largest pediatric medical centers in the US. Several locations throughout the region, serving more than 100,000 patient visits per year. We were only looking at some of those clinics. So what we wanted to do is we had this broad idea to come up with one simulation model that could actually be used by changing the parameters for the different clinics across the region. And I'll show you why the challenge that occurs there. So we're going to discuss the main site and the satellite site. And we have a paper and winter sim conference about this. Would like more details. So in the main, we were at a hospital's main campus. In the satellite, we were talking miles away from the main campus. At the main site, we had about service to about 40,000 orthopedic, sports medicine, cerebral palsy patients each year. The satellite mostly focused on orthopedic and sports medicine, so a slightly different patient population. The other difference we saw is teaching-based clinic versus a practice-based clinic. We've subsequently in other projects started to look at how to change operations based on a practice-based versus a teaching-based model, and how to actually optimize flow within a teaching-based model in a separate project. I think one of my PhD students might be online who could provide more information on that. But so we had these 2 clinics, but we saw they had actually very different features, who they served, how many people they served, and really even just the nature of the visit in terms of how many clinicians kind of came in. So our goal was to create a flexible simulation model, one simulation model that we could validate again across both of these clinics, and hopefully would allow for a simulation model that could go moving forward to continue to provide benefit even past kind of our working relationship. So we came up with this one flexible simulation model, and it was certainly a challenge, but lots of fun. So here's a typical patient flow. I won't go into all the details of our model. Arrival, check-in, waiting for the exam room, prepping. And sometimes there was actually 2 consults, especially if it was a teaching model where you'd have like a mid-level provider or resident come in first, then come out, talk with the physician, and then the physician or the attending come in next. It was the typical, there were multiple flows. Going back to the question of phlebotomy or radiology from before, in this case, we did actually have to model CAS services. And we did model the interactions with radiology, although we had to come up with an estimation of radiology services in this case. So here you see the number of patients per physicians were pretty similar, but the total number of patients were different, number of physicians. Here with the CAS services, clinical assistant staff. Again, we used this triangular distribution, and we looked at the differences in the times for both CAS services, X-ray, taking vitals, the checkout process as well in the system. Also, we saw differences in the percentage of patients that would have to go through each of the different steps in the process. So even though they had a very similar process in the fact that they are all orthopedic patients, they all had followed that timeline kind of I discussed before, we have different parameters that define the system. And again, we also saw that there was 3 different patient provider visit types. One where you only saw the MD, one where you only saw a mid-level provider, and one where you first visited the mid-level provider, the second visit was mid-level provider and MD. And so here's also where you see the change in terms of the breakdown among those different types of visits. I mean, we wanted to see, do you need to manage the system differently when the breakdown of visit types actually changes? So we created a simulation with parameters. We used, in this case, the previous example, we used Arena. In this case, we moved to AnyLogic as our simulation framework. And we were able to provide detailed simulation results, which I'll show you in a second. Similar to the previous ones, we did our validation. Again, we focused on wait time in the waiting area, wait time in total wait time, and then the length of stay. I'm sorry, waiting time in the room, and then length of stay in the room as well. Again, we did the length of stay in the room because we had those 3 different visit patterns as well. And so we were able to validate here. So here's a quick picture of the simulation model. Because we were trying to make it flexible, we really allowed for many different changes in the system. You could have the main or the satellite model. We looked at different patient volumes. We allowed them to change the number of physicians, the number of MLPs, which would in turn affect the number of patients per day, the number of patients per physician. In this case, we allowed them to have control over lots of different things, including the nurses, MLPs, check-in staff, CAS staff. We actually allowed for changing these check-in times and of all the distribution parameters because we were trying to create something that we could kind of hand off and could continue to be used after we left. Makes it more challenging in the actual development of it. The caveat I would make here, and if anyone was to ever do a similar project, is the communication with the actual clinic to make them understand that we cannot validate for any possible changes in the parameter, right? We have the most confidence with small changes from kind of the initial starting example. So that's always important to communicate, especially as you allow people to work with this. Part of our process, we actually handed this off and let the physicians and leadership run their own experiments. And then we kind of came back and saw what type of experiments they were running to make sure that they kind of were staying within a reasonable range. So we had lots of different parameters that we allowed them to change here. Again, as I mentioned before, we also allowed them to change. We did assignment of mid-level providers to physicians. We allowed them to share, have two mid-level physicians. Like we could have them shared between the different physicians. We could also have rooms shared between the physicians. And we actually allowed them more rooms than in case they ever expanded their clinic. And then finally, we looked at 2 different patterns. So a very extensive, probably the longest project and most detailed simulation model that my team has created to date. And this was the nice output that they came up with. They tried to create something nice in terms of with the different parameters. It will highlight any of these cells in yellow and orange if they're changed from those default values. And then it provided the output as well. So some of the insights we saw from this analysis, we did look at the difference in what does the patient experience look like depending on which of those different practice types they were looking at. And we were able to look at that both in the main site as well in the satellite site. In both locations, we found that patients wait the longest before their first visit with that mid-level provider over here. So what we did going into the concept of flexibility is we tried to look at new ways of thinking about pooling resources in MLP sharing or using independent MLPs. So in this case, we had 2 MLPs who were assigned to 2 physicians. So pooling resources, not fully, but giving a little bit more flexibility for that team to work together to 2 physicians. We also looked at the opportunity to have an independent MLP who ran a session without the presence of a physician. These were generally their urgent clinics where that would be possible. And so we looked at the effects of trying these different these different options here and the changes. And what the most interesting thing I think here was that it shows you the value of this simulation, because even though we're looking at 2 policies and there's a lot of similarities between the clinic, the relative benefit of employing either. Sorry, Massachusetts was trying to tell me to wear a mask. And that there's a COVID outbreak in Boston. Anyway, yes, so basically shows you, even though it's the same simulation, we can see different benefits, right? In the satellite site, we saw similar MLP sharing and independent. We saw the similar benefit. We saw differences when we looked at the main site. So again, goes to the value of, if we had just simulated one of these sites and said, oh, I'm sure whatever we find in this site can be translated to any of our other sites, we wouldn't necessarily be getting the benefit that we'd expect because of those different system parameters. So that was what one of the benefits we saw here, right? So for example, in the, we saw different changes in the length of stay, et cetera, for the MLP sharing versus the independent MLPs. So we saw that clinics with these similar features, oftentimes we can perhaps assume that the same policy change is going to affect it similarly, but actually we might find that that's not the case. Simulation provides us with one way to kind of go in there and really try and understand the effects. We created this graphical user interface to really make it valuable moving forward. And it also allowed for any changes to those parameters as we moved ahead. Okay, I think I'm getting close on time. Do we have any questions? And I'll do a very quick overview of that last section.
We do. Do you want to do the overview first, or do you want to get the questions?
No, let's do the questions first. Yeah.
All right. Okay, sounds good. We have a couple. We have another one from Anne. Oh, actually, we can wait for that one. So we have one from Stuart, and he was wondering if there were any virtual visits in any of these systems and how that could potentially affect the systems.
No, there weren't any virtual visits. This was years ago. So we didn't have any virtual visits. I think that that's a whole new component that we need to kind of look at, is how we integrate telemedicine into the workflows of the providers. You won't run into the room issues, but you'll start to see, perhaps you should actually have more physicians. I think there's lots to really be discussed there. But in this case, we didn't actually have it. But I think it's a ripe area for really rethinking flow patterns. Again, there's obviously a move towards telemedicine with COVID-19. We've have the move, especially as clinics have been opening up, thinking about how do you change your flow patterns to account for the 6 feet of distancing and trying to not have people cross paths as well. And so I think people are just kind of doing that on the fly and figuring it out. But I think that there's a lot of opportunity to think about that. And it is a good place for simulation, perhaps, to make an effect, especially when we think about the physical movement within the clinics. I know we've talked to at least 1 or 2 clinics just trying to brainstorm ideas with them on how they can take their clinic and kind of move it to a more COVID-19 friendly environment when you can't have these telemedicine appointments.
Mhm.
Good question.
And
I think lots of interesting stuff to do there.
yeah, and Marissa had a similar question, which you kind of answered, but how do you expect length of stay to change in clinics due to COVID? And in patient flows, do you expect there to be like an increased cleaning time, but with fewer patients being treated due to telehealth?
Yeah, no, I think that you kind of answered that well. I think it's going to really depend on the particular clinic. And that's another case in which it's going to be really hard to look at one clinic and say, this can be translated. Similar to this case, we saw 2 clinics, mostly similar patients. One had cerebral palsy clinic, which definitely ran differently than the others, but sports medicine. But even in those cases, you saw that different policies actually just affected differently because of the different nature. And so I hope that we will continue, for those working in healthcare simulation, to try to find this balance between, naturally, we always create these simulation models specific for clinics. And that's, what we need to do in order to validate them and verify them. But there is this intrinsic question of like, how as a discipline can we also move towards thinking about using simulation to provide kind of results that can translate elsewhere. It would be really great to have a simple model that would say, well, if you have these general parameters, then you should take this approach. But if you have these general parameters, this approach would be good. I think that's a great area and something we should move towards. The nature of how these projects are done is that you're going in and working for a particular clinic. And so we naturally want to get a simulation model that really nicely fits with that particular clinic, which oftentimes makes it more difficult to abstract findings that can go elsewhere. But I think we do need to continue really thinking about how to find that nice balance to have kind of a broader effect. And I think COVID, the response to the pandemic perhaps might lead people to start thinking in that direction. But it's all left to be seen. But yeah, you're dealing with how much is going to telehealth? What is the physical layout of the space? How much space is there? Like, can you have one-way flow? Can you have two-way flow? How quickly does the room have to be cleaned? All sorts of, it's going to be complex. And it would be great. It would be great if people were collecting data, but I don't know that it is. We work in we work with a diabetes clinic, and almost all their, we were designing a new strategy of care for them, but almost everything has kind of mostly gone online since then. So now we're in the process of trying to merge that together. So everything changes. We all need to be flexible, right?
Yeah, something we've learned. And this is more in terms of your research, but how many parameters did you allow to be changed by the physicians? And did you narrow this down for it to be usable by a physician audience?
For the previous one, we built that was given to physicians. It was given to like the physician leadership in the clinic. In this case, we allowed them to change so many things. I don't know if I could count. I'm guessing there depends on whether you consider each of these check mark boxes over here a different decision. So in this case, we really allowed, I don't typically do that in most of my projects. But the nice thing is what we found is when we kind of gave them the simulation before we finalized it, we found that they really were staying within the reasonable the realm of reason, right? Similar to the questions we got before, they're thinking in their head, what are people actually going to want to change? And though that typically keeps them close to kind of the starting point. But there were substantial amount of things that could be changed in this simulation.
We have a couple more questions, but if you'd like to like do the just like a quick to finish
Sure.
up your
So this actually kind of built on, so this was also before focusing on orthopedic outpatient clinics. We've worked with 2 over the time. We looked at this concept of, and actually I'm gonna, again, looking at different ways of prioritizing patients. And that actually is, so what we, all this animation slows you down. We looked at patients that had 2 different options. One is where they came, they saw the physician and they left. The second one was where they came to see the physician, then they needed to go and get a diagnostic test like an x-ray, and then before leaving, they needed to come back to the physician. And so the clinic we were working in had this question of, what do we do when the patients come back for the second time to see the physician? Do we just kind of add them to the end of the queue, which leads to really long wait times, or do we push them into the front of the queue, but perhaps kind of slows down everyone else in the system? And so we did have our simulation model, which built off of the one I already showed you. We also looked at using a continuous time Markov chain so that we could kind of study this more theoretically. We looked at a prioritized and a non-prioritized system. I'm going to go through this very quickly. We were able to solve these and go into all the details. And we actually went to look, we created one continuous Markov chain, which was 2-dimensional. We found that generally we got similar results to the simulation, but we saw that in these really high utilization cases, it was not a good approximation for the system. So we actually modified it to a 3-dimensional continuous Markov chain, which focused on which type of patient was currently in service. In this case, we actually saw we were able to get much better results by expanding the Markov chain to have a more detailed representation. Obviously, the model gets a lot bigger. And then finally getting to the flexibility. We looked at here at changing different ratios. We looked at 2 different patient types in terms of their arrival and their likelihood to have that second appointment. And let me run, I'm going to run to the flexibility part. We also finally created a hybrid prioritization using this continuous Markov chain. So very similar to what we saw in the first project. We kind of created a threshold where we said, can we redefine this continuous Markov chain so it's not fully prioritized or not prioritized, where we said, based on some system feature, we see the transition probabilities change. So you see a different structure to kind of the graph on the left versus the right. And so we were able to use a similar concept and similarly analyze the system that way, so that we could start to understand what should that threshold value actually be, and looking at the effects there. So in this case, I just want to throw this in there. I know the first 2 were simulation, but we have been also looking at other types of models that we might be able to use to look at this kind of hybrid resource sharing or hybrid prioritization framework. So that I think brings me to 5:30. I'm happy to answer like 1 or 2 questions. Feel free to email me if you have anything else as well. So thank you so much for having me.
Yeah, I think we're gonna just end it here just to make sure that the recording is like exactly the same. But thank you so much. It was super interesting. And thank you so much for taking time out of your busy schedule to talk to us.
Yep.
Yeah, thank you guys.
Okay, thank you all.